Yes, you can start.
Topic for the today's session is Varicella zoster virus and Epstein-Barr virus. Varicella zoster virus belongs to the alpha herpes virinae subfamily. First one is the Varicella zoster virus. Clinically, it will cause chickenpox in primary infection. 0% cases is noted before age 10. Peak incidence is at the age of 2 to 8 years. So the varicella zoster virus will enter through inhalation. Primarily, it will replicate in respiratory tract and it will invade lymph nodes. Viremia will spread virus to target organs. Incubation period of varicella zoster virus is 14 to 18 days. Rash appears first. It will appear on the head, next in the neck and trunk. The vesicles contain a clear fluid. New vesicles will appear in the first week. The varicella zoster virus chickenpox will have mild fever, malaise, and headache. The recovery is within 2 weeks. In adult, the infection is more severe and it will cause pneumonia. In neonates, it will cause encephalitis. Next one is the varicella zoster virus shingles. Shingles is the reactivation of varicella zoster virus. In shingles, the DNA will remain latent in ganglia and occurrence will increase with age. Onset of pain occurs before appearance of vesicles. Usually, it is unilateral. Immunosuppressed patients especially vulnerable. Next one is a complication. Most common infections are secondary bacterial infection of the skin, in which the CNS involvement will be there. Cerebellar encephalitis, aseptic meningitis. Most serious complication is varicella pneumonia. Next one is the Reyes syndrome. Reyes syndrome is characterized by fatty infiltration, myocarditis, corneal lesion, and arthritis. Next one is the chickenpox during pregnancy. Chickenpox during pregnancy will cause high risk of varicella pneumonia. It will cause fetal or congenital varicella syndrome. Congenital malformation in fetus is more frequent. It is characterized by cicatricial skin lesions. Limb hyperplasia will be there. Microcephaly in infants, the head will be smaller. Next one is the diagnosis. To find out a clinical picture, immunofluorescent antibody staining using biopsy. Next one is the treatment, supportive treatment, aclocyclovir for extreme cases. Next one is the prevention, immunoglobulin for patient at risk. Vaccine, live vaccine is used. Recommended dose for susceptible children aged 12 months to 12 years in 0.5 ml dose subcutaneously. For susceptible adolescent age 13 years, for adult 2 times 0.5 ml doses within 4 to 8 weeks is given. Next one is the Epstein-Barr virus. First one is the introduction. Epstein-Barr virus is associated with disease mononucleus. It is also known as kissing disease due to its primary mode of infection. Epstein-Barr virus has linked to mild childhood sickness, to infectious mononucleus in adolescent, and in Burkitt's lymphoma and nasopharyngeal carcinoma. Epstein-Barr virus was discovered in 1916 by Epstein and colleagues. Definite association with malignancy is able to transform cells, resulting in immortalization of cell. Two types of virus, A and B, which will occur in the same person. Epstein-Barr virus belongs to gamma herpes virus subfamily. Nucleotide is 100 nanometer in diameter with 162 capsomys. Membrane is derived by budding of immature particles through cell membrane. It is required for infectivity. Genome is linear double-stranded DNA molecule with 172 kilobase pair. Next one is the epidemiology. Two epidemiological patterns are seen with Epstein-Barr virus. In developed countries, two peaks of infection is seen. First one is in a very young preschool children age 1 to 6, and second one is seen in adolescent age 14 to 20. 80 to 90% of adults are infected. In developing countries, the infection is occur at earlier age. At the age of 2, 90% of children are seropositive. So the Epstein-Barr virus is transmitted by contact with saliva, particularly mainly through kissing. Next one is the pathogenesis or Epstein-Barr virus. Once infected, a lifelong carrier state develops whereby a low-grade infection is kept in check by the immune defenses. Low-grade virus replication and shedding can be demonstrated in the epithelial cells of pharynx of all seropositive individuals. Epstein-Barr virus is able to immortalize B lymphocytes in vitro and in vivo. A few Epstein-Barr virus immortalized B cells can be demonstrated in the circulation, which will be continually cleared by the immune surveillance mechanism. Epstein-Barr virus is associated with several other diseases. It may act directly or with the other cofactors. Next one is the disease association of Epstein-Barr virus. Epstein-Barr virus is associated with other diseases such as infectious mononucleosis, Burkitt's lymphoma, nasopharyngeal carcinoma, Limbo proliferative disease, X-linked Limbo proliferative syndrome, chronic infectious mononucleosis, oral leukoplakia in AIDS patient. Next one is the clinical syndrome. In children, prolonged low-grade fever and lymphadenopathy, cough and rhinorrhea, pharyngitis will be there. Role of Epstein-Barr virus in cancers. Epstein-Barr virus is thought to play a critical role in two cancers. First one is the Burkitt's lymphoma and next one is the nasopharyngeal carcinoma. The Epstein-Barr virus is a factor in these cancers, but the WHO lists Epstein-Barr virus as one of the 3 viruses known to be the causative agent in cancer. Next one is the infectious mononucleosis. Infectious mononucleosis prodrome 2 to 5 days, malaise, fatigue, possibly fever. In acute phase, the fever will last for 4 to 5 weeks. Lymphadenopathy, it will last for 2 to 4 weeks. Tonsillopharyngitis, splenomegaly, hepatomegaly, rash, abdominal pain, eyelid edema 50%. In resolution phase, organomegaly may persist up to 1 to 3 meter. Primarily, Epstein-Barr virus infection is usually subclinical in childhood. However, in adolescent and adult, there is 50% chance that the syndrome of infectious mononucleosis will develop. Infectious mononucleosis is usually self-limited disease. It consists of fever, lymphadenopathy, and enlargement of spleen. In some patients, the jaundice will be seen due to inflammation of hepatitis. Atypical lymphocytes are present in the blood. Next one is the complications occur rarely, but it will be serious. Example, splenic rupture will be there, meningoencephalitis and pharyngeal obstruction will be there. In some patients, chronic infectious mononucleosis may occur where eventually the patient dies of lymph proliferative disease or lymphoma. Diagnosis of infectious mononucleosis usually made by heterophile antibody tests and the detection of Epstein-Barr virus immunoglobulin M. There is no specific treatment for infectious mononucleosis. Acute infectious mononucleosis, it will have fatigue, malaise, 1 to 2 weeks, sore throat, pharyngitis, retroorbital headache, fever, myalgia, nausea, abdominal pain, generalized lymphadenopathy, hepatosplenomegaly. Next one is the Burkitt's lymphoma. Burkitt's lymphoma occurs endemically in parts of Africa. It is a common childhood tumor. It occurs at the age of 3 to 14 years. It is favorable to chemotherapy. It is restricted to areas with hollow endemic malaria. It appears that malaria infection is a cofactor. Multiple copies of Epstein-Barr virus genome and some Epstein-Barr virus antigens can be found in Burkitt's lymphoma cells, and patients with Burkitt's lymphoma have high titers of antibodies against various Epstein-Barr virus antigens. Burkitt's lymphoma cells show a reciprocal transcription between the long arm of chromosome 8 and chromosome 4 transcription is driven by Epstein-Barr virus infection. It is not caused by Epstein-Barr virus. Sporadic cases of Burkitt's lymphoma occur especially in AIDS patients. Next one is nasopharyngeal carcinoma. Nasopharyngeal carcinoma is a malignant tumor of the squamous epithelium of the nasopharynx. It is prevalent in South China, where it is the commonest tumor in men and second commonest in women. The tumor is rare in most parts of the world. It will occur in Africa, Malaysia, Alaska, and Ireland. Patients with nasopharyngeal carcinoma have high titers of antibodies against various Epstein-Barr virus antigen. Besides Epstein-Barr virus, there appears to be a number of environmental and genetic cofactors in nasopharyngeal carcinoma. In nasopharyngeal carcinoma, usually it will present late and the prognosis is very poor. In theory, the nasopharyngeal carcinoma can be prevented by vaccination. Next one is the immunocompromised patients. After primary infection, Epstein-Barr virus maintains a steady low-grade latent infection in the body. Should the person become immunocompromised, the virus will reactivate. In few cases, limbo proliferative lesions and lymphoma will develop. The lesions will tend to extranodal and unusual sites such as GI tract or the CNS. Transplant recipients, example renal, Epstein-Barr virus is associated with development of limbo-proliferative disease and lymphoma. In AIDS patients, Epstein-Barr virus is associated with oral leukoplakia and various non-Hodgkin lymphoma. Dukan X-linked limbo-proliferative syndrome. In this condition, it occurs mainly in males who had inherited a defective gene in the X chromosome. This condition occurs for half of the fatal cases of immunocompromised patients. Diagnosis in acute Epstein-Barr virus infection is usually made by the heterophile antibody test. Cases of Burkitt's lymphoma should be diagnosed by histology. The tumor can be stained with antibodies to lambda light chains, which should reveal a monoclonal tumor of basal origin. In over 90% of cases, the cell expresses immunoglobulin M at the cell surface. Cases of nasopharyngeal carcinoma should be diagnosed by histology. A patient with non-specific ENT symptoms who have elevated titri of Epstein-Barr virus immunoglobulin A should be given a thorough examination. Treatment of mononucleus is to manage the symptoms. According to Merck manual, antiviral agents have been proven not to be effective in shortening the course of infection or alleviating the symptom. It is advised to take acetaminophen or non-steroidal anti-inflammatory drug to help the fever and overall discomfort. Corticosteroid can be used to help alleviate swelling of the airway when necessary. Next one is the prevention. Prevention of Epstein-Barr virus is almost impossible with 95% of the world's population infected with Epstein-Barr virus. If one is trying to avoid infection, they can avoid contact with an infected person's saliva. Overall, there are not many methods of Epstein-Barr virus infection prevention. Thank you.